Welcome. In the previous session, we have discussed about direct ocular trauma, both open globe and closed globe injuries. And in this session, we will be discussing about ocular morbidities arising from trauma at a distant non-ocular site, also known as indirect ocular trauma, and also photic or light-induced ocular injuries, which include iatrogenic laser-induced retinal injuries. In the next session, we will be discussing about iatrogenic ocular morbidities due to radiation exposure and systemic medications. Among indirect ocular trauma, we have Purtscher retinopathy, Terson syndrome, Valsalva retinopathy, shaken baby syndrome, and Whiplash maculopathy. Purtscher retinopathy refers to a pattern of retinopathy occurring following non-ocular injury at a distant site, whereas Purtscher-like retinopathy refers to the occurrence of similar findings as Purtscher retinopathy but from causes other than trauma. Traumatic causes which can lead to Purtscher retinopathy include severe head trauma, particularly compressive head trauma, long bone fractures, chest compression injury, and hydrostatic pressure injury, which occurs due to inadvertent injection of high pressure fluid. Non-traumatic entities which can lead to Purtscher-like retinopathy include acute and chronic pancreatitis, connective tissue diseases such as systemic lupus erythematosus, thrombotic thrombocytopenic purpura, chronic renal failure, orbital steroid injection, and retrobulbar anesthesia. These entities occur due to occlusion of precapillary retinal arterioles with clots having sizes within a specific range arising either from leuco or white blood cell embolization, fat embolism, air embolism, or amniotic fluid embolism. Purtscher retinopathy is typically a bilateral condition and is usually associated with painless loss of vision, and the presenting visual acuity can range from 20 by 20 to counting fingers. The fundus changes may be detectable soon after the predisposing event and may progress further for another 1 to 2 days. A ring of cotton wool spots surrounding the optic nerve is the classic presentation as seen here in this clinical photograph due to occlusion of superficial capillaries in the radial peripapillary capillary network. Like cotton wool spots in other entities, these lesions have fluffy edges and may overlie retinal blood vessels. The other lesion characteristic of Purtscher and Purtscher-like retinopathy are polygonal areas of whitish opacification of deep retina between the retinal vessels as seen here in this clinical photograph, which are also called Purtscher flecken and which occur due to occlusion of deep retinal capillary plexus. They typically have a zone of normal retina between themselves and the adjacent blood vessels and have more distinct edges as compared to the peripapillary cotton wool spots. They are located in the posterior pole and are pathognomonic of Purtscher and Purtscher-like retinopathy occurring in 50% of these patients. Intraretinal hemorrhages and retinal edema can also be found in these entities. Fluorescein angiogram shows normal choroidal filling, which suggests that the choroidal circulation is not affected by these clots, followed by focal areas of arteriolar obstruction and capillary non-perfusion as seen here in this fluorescein angiogram, and disc leakage and venous staining in later phases of fluorescein angiogram. OCT scanning through the opaque patches show either hyperreflectivity of the inner retinal layers as seen here in these OCT images, or hyperreflectivity of only the inner nuclear layer in the middle portion of the retina, which is also known as paracentral acute needle maculopathy, which we have discussed in a previous session. The opaque patches disappear over time, with almost half of patients with Purtscher retinopathy having improvement of vision, but the remainder develop macular RPE changes and optic atrophy without significant recovery of vision. There is no definitive treatment for Purtscher retinopathy, but reports suggest possible beneficial effects of high-dose intravenous steroids, and treatment of the predisposing condition is imperative to prevent further damage of the retina, and systemic workup is required for a patient presenting with Purtscher-like fundus without a history of trauma or without the history of a medical condition known to predispose to Purtscher-like retinopathy. Terson syndrome is defined as occurrence of intraocular hemorrhage in association with intracranial hemorrhage due to acute elevation of intracranial pressure, which is transmitted to the optic nerve sheath, which obstructs venous drainage from the eye, which leads to acute elevation of intravascular pressure in the retinal blood vessels, which leads to rupture of these vessels. Terson syndrome most commonly occurs following subarachnoid hemorrhage, typically following rupture of intracranial aneurysms, or subdural hemorrhage, typically following trauma, and it has been estimated that 20% of patients with intracranial hemorrhage develop intraocular hemorrhage. It has been found that occurrence of intraocular hemorrhage following intracranial hemorrhage worsens the systemic prognosis for the patient. Intraocular hemorrhage of Terson syndrome typically develops within 24 hours following intracranial hemorrhage, and almost half are bilateral. Various patterns of intraocular hemorrhages can be found in Terson syndrome as seen here in this clinical photograph, and these include vitreous hemorrhage, subhyaloid and sub-ILM hemorrhages, which are said to be more common in Terson syndrome, retinal hemorrhages, including Henle's layered hemorrhage in deep retina, which has a petaloid pattern around the fovea as seen here in this clinical photograph, and subretinal hemorrhages. This OCT image shows a dissolving subretinal hemorrhage at the fovea corresponding to this lesion on the color photograph, and this OCT image shows a sub-ILM hemorrhage corresponding to this lesion on the color photograph, with this being the detached posterior hyaloid, and this OCT image shows Henle fiber layered hemorrhage. With resolution of intraocular hemorrhages, visual acuity improves to 20/50 or better in the majority of patients with Terson syndrome. Vitrectomy for vitreous hemorrhage is indicated for bilateral vitreous hemorrhage, non-resolving vitreous hemorrhage, and in young patients who are prone to develop amblyopia. Valsalva retinopathy refers to intraocular hemorrhage following Valsalva maneuver. Valsalva maneuver is a sudden elevation of intrathoracic and intraabdominal pressure against a closed glottis, such as may occur during lifting heavy weights, coughing, straining during bowel movements, cardiopulmonary resuscitation, and Heimlich maneuver. Valsalva retinopathy is pathogenetically similar to Terson syndrome in that it occurs due to sudden elevation of intravascular pressure in the ocular venous system, and this leads to rupture of retinal capillaries. Valsalva retinopathy typically demonstrates a subinternal limiting membrane hemorrhage, as seen here in this clinical photograph, due to rupture of superficial retinal capillary plexus in or near the central macula, with the shape of the hemorrhage being either dumbbell, oval, or round. The clinical characteristics of a sub-ILM hemorrhage is a glistening finely striated surface which represents the internal limiting membrane, a double ring sign with the outer ring corresponding to the zone with subhyaloid hemorrhage and an inner ring corresponding to the zone with sub-internal limiting membrane hemorrhage, and a yellow demarcation line called the arcus retinalis, which represents the peripheral extent of internal limiting membrane detachment. Subinternal limiting membrane hemorrhage may cause breakthrough subhyaloid and vitreous hemorrhage. Henle layered hemorrhages occurring due to rupture of deep retinal capillary plexus and subretinal hemorrhages can also be found in an eye with Valsalva retinopathy. This OCT image shows a subinternal limiting membrane hemorrhage with posterior shadowing, with this line representing the posterior vitreous cortex and this line representing the internal limiting membrane. The hemorrhages in Valsalva retinopathy typically resolve spontaneously with restoration of vision, and this clinical photograph shows a residual ILM detachment following resolution of sub-ILM hemorrhage. Shaken baby syndrome is also known as abusive head trauma or non-accidental trauma in infants and young children. The usual history in such a scenario is violent shaking of a child. In a young child presenting with clinical manifestations of shaken baby syndrome, absence of this specific history of violent shaking and inconsistent accounts of preceding events by different family members is always suspect. Intraocular manifestations of shaken baby syndrome can occur in 30 to 40% of young children who have been violently shaken. These patients are less than 5 years of age, with most being less than 12 months of age, and the intraocular and intracranial manifestations of this entity occur in these young children following shaking because their poorly developed neck muscles cannot stabilize a proportionately larger and heavier head against acceleration and deceleration during shaking. The intraocular manifestations are hypothesized to occur either due to movement of the vitreous causing shearing of the internal limiting membrane and superficial retinal blood vessels, or due to raised intraocular venous pressure following intracranial hemorrhage or Valsalva maneuver during shaking. Clinical features of shaken baby syndrome can be unilateral or bilateral and are characterized by retinal hemorrhages, which are often white-centered, as seen here in these two clinical photographs, which most commonly occur in the posterior pole but may also affect the peripheral retina and usually resolve with time. Retinoschisis, usually hemorrhagic, which can persist indefinitely, and full thickness perimacular folds concentric to the macula, as seen here in this clinical photograph, which are highly characteristic of this condition and usually flatten out over time. Other clinical signs include vitreous, subretinal and subhyaloid hemorrhages, optic nerve swelling from intraorbital optic nerve sheath hemorrhage, cotton wool spots, macular edema, macular hole, retinal ischemia, and rarely retinal break or retinal detachment. Later, pigmentary alterations in retinal pigment epithelium and optic atrophy may develop, but typically anterior segment and ocular adnexa appear normal. Neurological manifestations of shaken baby syndrome are intracranial hemorrhages, typically subdural and subarachnoid hemorrhages from rupture of bridging veins, which occurs during violent shaking. This CT scan image shows 2 episodes of subdural hemorrhage in a patient with shaken baby syndrome. Other neurological signs include intracerebral hemorrhage, cerebral contusion, cerebral ischemia, and cerebral edema. Later, cerebral atrophy can develop, but external manifestations of injury such as skin bruises and bone fractures are uncommon following violent shaking. Relevant investigations for suspected shaken baby syndrome include neuroimaging and CSF tap, and OCT imaging with handheld OCT devices for children may show the characteristic posterior segment features of shaken baby syndrome such as retinoschisis and retinal folds. Differential diagnosis of suspected shaken baby syndrome are important to consider and includes Terson syndrome, vaginal delivery, cardiopulmonary resuscitation, sepsis, blood dyscrasias, arterial hypertension, acute rise in intracranial pressure, and glutaric aciduria. Vitrectomy may be required for non-resolving vitreous hemorrhage to prevent amblyopia, and many countries require by law that clinician report suspected cases of child abuse to government agencies. A mortality rate of as high as 30% has been reported among patients with shaken baby syndrome, and the remainder may have persistent neurological deficits such as learning disability, cognitive and motor abnormalities, and persistent visual impairment, most commonly from cortical injury, but also may occur from optic atrophy. Whiplash maculopathy is bilateral mild blurring of vision immediately following a whiplash injury to the head in adults. Whiplash injury is sudden flexion extension of the head and neck, typically after sudden deceleration during an automobile accident. Ophthalmoscopy shows faint gray haze with a small depression in the fovea, as seen here in this clinical photograph, and OCT shows disruption of the IS-OS junction. This clinical pattern is similar to that following photochemical injuries, which we will discuss later in this session. With time, the gray-colored lesions resolve, but visual acuity recovery is often incomplete. Photic injury refers to damage to tissues, specifically the retina and the choroid, due to absorption of light energy by these tissues. Photic injury mechanisms can be photomechanical, photothermal, and photochemical, which we will be discussing in this session. And more than one mechanism can occur in one particular incident. The visible spectrum comprises a very small proportion of the entire electromagnetic spectrum, and wavelengths shorter than those in the visible spectrum comprise the UVA, UVB, and UVC portions of the ultraviolet spectrum, and wavelengths larger than those in the visible spectrum comprise the infrared spectrum. The cornea absorbs almost all wavelengths below 300 nanometers, whereas the crystalline lens, particularly aged crystalline lenses, absorb most UVB, UVA, and visible blue light. But in eyes of young individuals, the crystalline lens may transmit potentially harmful UVB radiation around 320 nanometers. Other ocular defense mechanisms include shielding by eyebrows, blinking, reflection of non-perpendicular light from corneal surface, pupillary response to light, choroidal circulation, which controls temperature rise in light-exposed tissue, and antioxidant molecules, specifically lutein and zeaxanthin in the macula. Molecules in the retina and choroid which absorb light include melanin and hemoglobin, which absorb the major proportion of light entering the eye and falling on the retina, xanthophylls namely lutein and zeaxanthin in the macula, photopigments in the photoreceptors, and lipofunctin in retinal pigment epithelium. This diagram shows the absorption efficiency at various wavelengths of melanin, hemoglobin, xanthophyll and rhodopsin, as well as the phototoxic efficiency of lipofunctin at various wavelengths, which we will be discussing later in this session. Retinal light exposure can be defined by the following parameters: optical energy, power, that is energy per unit time, radiant exposure, that is energy per unit area, and irradiance, that is power per unit area or energy per unit area per unit time. And it is important to remember that with an ophthalmic laser, if power setting is held constant, reducing the spot size increases irradiance at the target tissue. Light-tissue interaction depends on the wavelength of the incident light, which determines whether and to what extent the incident radiation is absorbed by the target tissue, and the energy delivered to the target tissue, which in turn depends on the output power of the light source. The duration of exposure, which determines the total energy delivered, and the duration of exposure depends on whether the exposure is continuous or pulsed, which we will be discussing later in the session on retinal laser photocoagulation and collimation of the beam, which determines the irradiance at the target tissue, collimation meaning the extent of alignment of constituent waves within the incident beam at the instant of reaching the target tissue. Photomechanical injury refers to disruption of tissue caused by exposure to very high energy incident light of ultra-short duration, typically ultra-short duration very high irradiance lasers. The laser energy is absorbed primarily by melanin, causing rapid tissue heating and water vapor production, with formation and subsequent collapse of microbubbles which distort tissue and cause microrips within the tissue. Clinical signs of photomechanical chorioretinal injury include focal RPE damage, chorioretinal bleeding as seen here in this clinical photograph, and macular hole formation. Following resolution of the associated hemorrhage, OCT usually shows focal disruption of the outer retinal layer, and the size of the disruption increases with increasing damage severity. Other features which may be detected on OCT and may persist or spontaneously resolve include sub-ILM hemorrhage as seen here in this OCT image, which occurs immediately following the injury, macular hole as seen here in this OCT image, which may occur immediately or later following the injury, macular neovascularization and epiretinal membrane, which usually occurs later following the injury, and RP irregularity and hyperreflectivity as seen here in this OCT image. Photomechanical effect of lasers can also be used for therapeutic purposes, as in photodisruption, which causes ionization of tissue, as with Nd:YAG laser, and femtosecond laser-assisted cataract surgery, photoablation, which breaks bonds between molecules, as with excimer laser, which is used for LASIK and photorefractive keratectomy, and photovaporization, which causes rapid water vapor expansion, as with holmium laser, which is used for creating sclerostomies. We may note here that none of the therapeutic applications of photomechanical effect of lasers utilize the retina as the target tissue. Photothermal injury refers to tissue burns caused by exposure to relatively long duration high irradiance light, but not so high as to cause photomechanical injury. Photothermal injuries are also typically caused by lasers, but with these radiation characteristics. The energy of the incident light is absorbed chiefly by melanin in RPE and choroid, producing heat which is conducted to the overlying retina, increasing the temperature of the target tissue, resulting in coagulative necrosis, which is caused by protein denaturation. The heat is also conducted to the surrounding zones, resulting in collateral damage. The severity of the burn depends on fundus pigmentation and on the power, duration, and size of the laser spot. At the site of exposure, a retinal burn is created, as seen here in this clinical photograph, in which the normally translucent retina becomes opaque and white immediately following exposure, and this is called the laser burn. Over next few months, focal RPE damage and pigment clumps occur at the burn site, as seen here in this clinical photograph, and these are known as laser scars. The size of the burn may appear to increase over time because of scarring of collateral damage surrounding tissues, which appear normal immediately following exposure. Unlike photomechanical injury, choroidal hemorrhage and full-thickness macular holes do not occur in exclusive photothermal injuries because there is no tissue disruption, and this is important to remember. At the site of a moderate to severe burn, OCT shows hyperreflectivity of a column of full-thickness retina, as seen here in this OCT image at the sites of retinal burns. But mild retinal burns may show hyperreflectivity localized only to the outer retina. The hyperreflectivity fades over time, and with development of laser cuts ophthalmoscopically, focal areas of RP thickening and irregularity can be detected on OCT at the sites of the laser burns. Photothermal effect of lasers is used therapeutically in retinal laser photocoagulation, which we will discuss in a subsequent session. Photochemical injury, also known as phototoxic retinopathy or simply photic retinopathy, is the occurrence of retinal and/or retinal pigment epithelial dysfunction and damage caused by exposure to intense light for a long duration, and exposures which exclusively cause photochemical injuries do not increase retinal temperature to such an extent as to cause photocoagulation, but photochemical reactions can be promoted by associated rise in retinal temperature following exposure and also by increased blood oxygen levels. The clinically relevant type of phototoxic retinopathy occurs when liposuction in retinal pigment epithelium absorbs ultraviolet light to generate reactive oxygen species which damage molecular constituents of the surrounding tissues, and the shorter the wavelength of the ultraviolet light, the more the hazard. Several risk factors have been implicated to increase the risk of phototoxic retinopathy, including duration, intensity, and wavelength of radiation, young age, emmetropia, clear ocular media, pupil dilatation, fundus pigmentation, pre-existing retinal diseases, poor nutritional status with inadequate availability of antioxidants, ascorbic acid and vitamin A, and raised blood oxygenation levels, core body temperature, and use of photosensitizing agents such as hydrochlorothiazide, hydroxychloroquine, benzodiazepines, and tetracyclines. 24 to 48 hours after exposure, a yellow-white lesion can be detected, as seen here in this clinical photograph, and over the next several weeks, this lesion fades with or without development of pigment mottling lamellar holes and epiretinal membrane. OCT initially shows diffuse hyperreflectivity of a full-thickness column of retina, as may occur following photothermal injury, but some eyes may show curvilinear columns of hyperreflective Henry's layer in the early stage, as seen here in this OCT image. Later, a well-defined defect appears in the outer retinal layer, as seen here in these two OCT images, typically over normal appearing retinal pigment epithelium, but in some cases the retinal pigment epithelium may also appear to be damaged. OCT cannot definitively differentiate between phototoxic and photothermal injuries because in both entities OCT shows hyperreflectivity of a full thickness column of retina. Following phototoxic injury, fluorescent angiography may acutely show dye leakage, and later the fluorescent angiogram may be normal or may show transmission defects. Fundus autofluorescence may be normal or show hyperautofluorescence in the affected zone. Next, we will discuss briefly the various scenarios in which photic injury can occur. Accidental exposure to laser can cause photomechanical and/or photothermal injuries and can take place in industrial, military, academic, and recreational settings. It can occur from both direct and reflected laser beams. Patient complains of perceiving an extremely bright flash followed immediately by scotoma, and some patients may report hearing an audible sound or perceiving momentary ocular pain at the time of injury. Initially, hemorrhages may be found in the posterior segment, such as subretinal, retinal, subhyaline, and/or subhyalite hemorrhages, and in some cases, a full-thickness macular hole may occur immediately following laser injury. Later, the hemorrhage subsides and macular neovascularization, epiretinal membrane, and full-thickness macular hole may develop. Depending on the tissue response, visual acuity may improve after resolution of hemorrhage or may further deteriorate. FDA has approved laser pointers which have a power output of less than 5 milliwatts because blinking or aversion reflex, which occurs within 1/4 of a second following exposure, prevents retinal damage with this or a lower power output, but prolonged viewing of these lasers can also cause retinal damage. Recreational lasers used for entertainment purposes, which may appear similar to laser pointers, have a much higher power output of 10 milliwatts to 1000 milliwatts, and this level of energy exposure is sufficient to cause retinal damage before a normal blink or aversion reflex. These recreational lasers usually emit green or blue laser as compared to the red laser of low power laser pointers. Iatrogenic retinal injuries can occur during retinal laser photocoagulation when the fovea is photocoagulated inadvertently. When using a combined capsulotomy SLT Nd:YAG laser system when attempting capsulotomy but using the SLT mode instead of the capsulotomy mode, and during cosmetic laser procedures on the skin. These patients need to be followed up for development of macular neovascularization, full thickness macular hole and epiretinal membrane, treatment for which may benefit these patients. And macular neovascularization and full thickness macular hole following laser injuries are also known to resolve spontaneously. Prevention against laser injuries is important to consider and includes wearing wavelength specific laser safety goggles both by the surgeon and any bystander to protect from both stray and diffuse laser beams, proper training of personnel operating laser machines, proper maintenance of laser machines, and careful mode selection when using combined capsulotomy SLT laser devices for capsulotomy. This table shows the classification of laser devices based on safety, with class 1 being safe for unrestricted use and class 3B and class 4 having moderate to severe risk of ocular hazard. Photochemical injuries can also be accidental or iatrogenic. Accidental photochemical injuries include solar retinopathy and Welders arc retinopathy. Solar retinopathy typically occurs when viewing partial solar eclipse without appropriate ocular protection, but solar retinopathy can also be caused by viewing the sun otherwise for a prolonged period, particularly with telescopes or dilated pupils, which increase the energy delivery to the retina. Primary foveomacular retinitis is a similar condition which occurs in young adults exposed to hot, bright, sunny environments for long duration but without history of sun gazing, and typically army personnel, sunbathers, and people with psychiatric disorders are prone to this form of solar retinopathy. Welders arc maculopathy occurs in individuals using Welders arc without ocular protection, particularly younger workers. The retinal injury following exposure to Welders arc may be obscured by concomitant painful erosive keratopathy. The symptoms and clinical course of Welders arc maculopathy are similar to those of solar retinopathy. Patients having solar or Welders arc maculopathy complain of visual symptoms such as blurring of vision, erythropsia, photophobia, metamorphopsia, and or micropsia after several hours following exposure, unlike photomechanical and photothermal injury where blurring of vision occurs immediately following exposure. As we have mentioned earlier in this session on ophthalmoscopy, in the acute stage, a small yellow-white foveal lesion can be detected after several hours following exposure, and over the next several months, the foveal lesion resolves and visual acuity improves in most patients, but residual metamorphopsia and paracentral scotoma may persist. Iatrogenic photochemical injuries include injuries following exposure to operating microscope and endoilluminators used during vitreous surgery. Although they are photochemical retinopathies, thermal injury may contribute by promoting the photochemical reactions. Operating microscope injury typically cause a 0.5 to 2 disc diameter oval yellowish white lesion as seen here in this clinical photograph, and these lesions are often decentered slightly inferiorly. Endoilluminator induced injuries as seen here in this clinical photograph are typically even larger and can occur in an extrafoveal or even an extramacular area. The yellowish white lesion that develops takes hours to appear and are not detectable intraoperatively, and this is important to remember. Over time, the lesion fades and in severe cases Chorioretinal atrophy and hyperpigmentation may occur, sometimes followed by macular neovascularization. Preventive measures which can be taken while using an operating microscope include reducing the duration and intensity of exposure to coaxial illumination, using oblique illumination and pupil shields whenever possible, and filtering wavelengths less than 515 nanometers. Preventive measures while using endoilluminators during vitreous surgery include reducing the duration and intensity of exposure, positioning the endoilluminator as far as possible from the retina, and filtering wavelengths less than 515 nanometers, and also consideration regarding discontinuing photosensitizing medications, which we have mentioned earlier in this session, whenever possible prior to exposure to operating microscope and or endoilluminator illumination. Fundus photography and indirect ophthalmoscopy are not known to cause photic retinal injury. To recap the salient points, Purtscher retinopathy occurs following injury at a distant non-ocular site such as long bone fractures and compressive head injuries. Purtscher-like retinopathy, a similar entity, occurs following non-traumatic non-ocular conditions such as pancreatitis, systemic lupus erythematosus, and childbirth. It occurs due to occlusion of precapillary retinal arterioles by clots arising from leukoembolization or fat, air, or amniotic fluid embolism. Ophthalmoscopy shows peripapillary cotton wool spots and pathognomonic plaque-like well-defined areas of deep retinal whitening. It is usually associated with visual loss, after which half have visual improvement and the remainder have persistent visual impairment from RPE changes and optic atrophy. Terson syndrome is the occurrence of intraocular hemorrhage in patients with intracranial hemorrhage. It occurs due to transmission of raised intracranial pressure to the optic nerve sheath, which obstructs ocular venous drainage, raising intravascular pressure in retinal blood vessels. 20% of patients with intracranial hemorrhage develop intraocular hemorrhage, and they have a worse systemic prognosis. Otherwise, the majority of patients have improvement of vision following resolution of hemorrhage. Valsalva retinopathy occurs following Valsalva maneuver due to transmission of intravascular pressure to the ocular venous drainage. It is characterized by intraocular hemorrhages, typically sub-ILM hemorrhages. Shaken baby syndrome occurs in young children, mostly infants, following violent shaking. Characteristic ocular manifestations include white-centered retinal hemorrhages, retinoschisis usually hemorrhagic, and perimacular full-thickness retinal folds concentric with the macula. Non-ocular manifestations of shaken baby syndrome include intracranial hemorrhages and brain injury. External manifestations of injury in violently shaken young children are uncommon. Shaken baby syndrome patients have a significant mortality rate, and the remainder have a high incidence of neurological and visual impairments. Many countries require by law that clinicians report suspected cases of child abuse to government agencies. Photic injuries can be photomechanical, photothermal, or photochemical. Photomechanical injury occurs due to exposure of the retina to very high irradiance of ultra-short duration, typically with lasers, which cause tissue disruption, leading to choroidal rupture, subretinal hemorrhage, and or full-thickness macular hole, and can predispose to subsequent development of macular neovascularization. This exposure to laser can be accidental, non-accidental, or iatrogenic. Photothermal injury occurs due to exposure to lasers of high irradiance but of relatively longer duration, which cause coagulation of tissue, resulting in a chorioretinal burn which appears white immediately after exposure and later shows scarring with pigmentation, and can also predispose to subsequent development of macular neovascularization. This usually occurs when the fovea is inadvertently photocoagulated due to error in localizing the intended area of treatment through the contact lens used for photocoagulation. Photochemical injury occurs due to excessive exposure to ultraviolet radiation, which is absorbed by lipofuscin in retinal pigment epithelium, generating reactive oxygen species which damage and destroy adjacent retina. Clinically, a yellowish-white lesion appears at the site of injury several hours after exposure, which later shows a defect in the outer retinal layer or nocity. Examples of retinal photochemical injuries include non-iatrogenic injuries such as following sun or solar eclipse viewing and welding arc injury, and iatrogenic injuries such as following exposure to operating microscope and endoilluminators used during vitreous surgery. Thank you for listening.